So for this section, what we're going to talk about is how to think about diabetes. Now, diabetes is a process that is caused by insulin resistance. So we're going to talk all about insulin and insulin resistance and how that develops. Um, but there's a couple of different ways that we can look at diabetes. So one technical definition of diabetes is a disorder that disrupts the way that your body uses glucose. So type 1 diabetes, your body doesn't make insulin. It no longer makes insulin. And you need to take insulin in order to control your glucose. Type 2 diabetes, as we'll see, the body has too much insulin and has trouble maintaining glucose management. So that's one way to look at it. Another way is what we're talking about in type 2 diabetes, which is thinking about it in terms of the process. So diabetes is a disease of insulin resistance, eventually leading to decreased insulin secretion. Now we'll talk all about that, but really what we're looking at here is the body doesn't respond to insulin in the same way. Pancreas has to produce more and more insulin in order to maintain blood sugars until the pancreas hits a point where it can no longer keep up and insulin secretion actually starts to drop, and that's when we see the blood sugars go up and we see diabetes. But there's a third way to look at this, and I think this might be the best definition. And really what we're saying here is diabetes is a disorder of energy overload. So it's a story of how the body tries and ultimately fails to accommodate. And each person has a different threshold here. And so this is what's very, very fascinating for this, because while one person may develop diabetes in a shorter period of time and somebody else may develop in a longer period of time, and one person may become more overweight and one person may become less overweight, it's really the body's ability individually and genetically to cope with the energy overload that counts. So let's step back a little bit and talk about what happens when we eat. So when we eat, food has energy in it, and food is composed of fat, protein, and carbohydrates. And so the energy nutrients, the energy is really captured in the bonds between the carbons in these foods. So we eat them, and our digestive process breaks them down. So we break fats down into fatty acids and proteins down into amino acids, and carbohydrates break down into glucose. And if we look at fat, now this is a bit of a complicated picture and we won't go all the way through it, but essentially we absorb the fat. Doesn't actually go into our bloodstream right away, goes through our lymphatics, comes into the venous system first, gets circulated around the body. So the tissues that rely on fat for their energy, they'll take up the fat and use them. And then eventually it comes back to the liver. And this is going to be important because the liver is the quarterback in metabolism here. Protein, so proteins, when we eat proteins, they're composed of amino acids, and these are the building blocks for proteins. There are 9 essential amino acids, so we have to eat them, we cannot make them. The rest of the amino acids we can actually make from these 9 amino acids, so there's lots of pathways to convert one amino acid to another, but there are 9 that we need to eat. The interesting part with protein is that by and large, we use proteins to make other proteins. We use it to build muscle. We use it to manufacture all the useful compounds in our bodies tend to be proteins. So we build proteins from amino acids that come from the protein that we eat. Generally, we don't rely on protein for energy. So protein can be turned into energy. Protein can be turned into glucose. Protein can also be turned into fat. If we overeat protein, and we're overeating in general, the protein will actually get turned into fat predominantly. And then carbohydrates. Now, carbohydrates in diabetes are kind of the essential macronutrient that we look at. So there's 3 types of carbohydrates: sugars, starches, and fiber. And really kind of the way to look at this is sugars are simple, very simple. They convert to glucose very quickly. They affect the blood sugar and insulin response. So, the sugars cause insulin to go up. The starches are more complex, and so some of the starches are simple and get converted to glucose very quickly. Some can be complex and take time to break down, and over time they have little effect on insulin release. And fiber does not get absorbed, and so the fiber actually serves as food really for our gut microbiome, the bacteria in our gut. So the fiber is essential for us, and it's very, very important. Fiber slows down the absorption of glucose in the total food product. So when we look at the amount of fiber in a food, it can be very useful in terms of kind of evening out the glucose response. But by and large, we're looking at it from this perspective. So what happens when we have carbohydrates is the carbohydrate gets broken down to glucose. The glucose gets absorbed into the blood from the small intestine. That small increment raising the blood sugar causes the pancreas to release insulin to to essentially control the blood sugar. Insulin will help the body's cells absorb that glucose. But the key thing to think about with insulin is while it's triggered predominantly by carbohydrate, insulin is a storage hormone. Insulin wants to store, so it's going to help the body and the cells absorb glucose, but it's also going to help with fatty acids and amino acid absorption. It's going to stop the breakdown of stored glucose, stored fat, and stored amino acids or protein. And it's also going to start helping to build things. So it'll help building glycogen, so that's the storage form of glucose. It'll help with the building of proteins, but it'll also help with the building of fat. So essentially, high levels of insulin are going to cause you to gain weight and are going to cause you to stop or not be able to burn fat. So remember that insulin is a storage hormone. What's this? It's a teaspoon of sugar. A single teaspoon of sugar represents all the glucose. So if that was glucose there, represents all the glucose circulating in your bloodstream at one time. Very important to think of it this way. So let's step back and think about if we drink a glass of orange juice. A glass of orange juice is about 6 teaspoons of sugar. Now, the sugar in orange juice is actually a combination of glucose and fructose. So to be technically correct, it's 3 times the amount of glucose that's circulating in your body. So think about that for a moment. You just drank that orange juice, it gets absorbed very quickly. You've just loaded your blood with 3 times the amount of glucose that is currently circulating. Now, this may kind of cause you to stop and think, wow, that's impressive. It's also impressive to think that when people are in hospital and they have a low blood sugar, even if they have an IV in, what we do is we actually give them orange juice because the orange juice will trigger the release of insulin better because it gets absorbed in the small intestine. So it actually increases insulin much more quickly than does just injecting the glucose into the intravenous. So when that glucose is detected and it comes into the bloodstream from the small intestine, the beta cells in the pancreas release insulin in response to the glucose levels. Normally, that results in about 80 to 90% of the glucose being stored as glycogen in the muscles. The glycogen in the muscle is essentially the great glucose sink. So muscles are a buffer. Muscles are a buffer, so they allow you to absorb glucose, store it as glycogen. The glycogen is predominantly used for future activity, but the glycogen can also be used to supplement glycogen in the liver. So basically through something called the Cori cycle, glycogen can break down into lactate, and lactate can come back to the liver and be turned into glucose. The liver also stores glucose as glycogen. And so when we fast, the liver essentially produces glucose from glycogen for the brain and body at about 1 teaspoon per hour. Any remaining glucose gets turned into fat. So if there's more glucose than we need to store as glycogen in either our muscle or our liver, it'll get turned into fat. And so the liver will do that, and that's called de novo lipogenesis. So what about when we're not eating? So that's what happens when we eat and food comes in. What about when we don't eat? So essentially here, when we're fasting, it's all about the liver. And the liver's job is to produce enough sugar, enough glucose to maintain blood glucose levels. And so normal is less than 5.5 millimoles per liter. And roughly speaking, that 5.5 millimoles per liter is that 1 teaspoon of glucose. The body's requirement are 2 teaspoons per hour. The brain will take 1 teaspoon of glucose an hour. The rest of the body will take another teaspoon per hour. And the liver responds to the pancreas. The pancreas will send out insulin if it wants it to slow down the production of glucose. It'll produce glucagon if it wants to speed it up. And this stays in balance. And the liver will take and create the glucose from either breaking down glycogen, which is the stored form of glucose, or from gluconeogenesis, which is a process whereby proteins and fat, the glycerol backbone of triglycerides, can be turned into sugar, or from lactate, from the Cori cycle that we talked about. All of those can be actually broken, turned back into glucose. And so when we're not eating, when we're fasting, we maintain our blood sugars by having the liver produce a couple of teaspoons per hour. So what happens in diabetes? So first of all, the process of diabetes, the underlying process is this concept of insulin resistance. And this is really the notion that it takes more and more insulin to store the same amount of glucose. So we drink a glass of orange juice and we need to produce more glucose or more insulin. And insulin resistance happens over time for a variety of reasons. So age can play a factor. We're more insulin sensitive when we're 20 than when we're 50. Genetics absolutely, so if you have a family history of diabetes or insulin resistance, you're more likely to have diabetes or insulin resistance. Weight gain. So we're going to see that insulin resistance can cause weight gain, but weight gain itself can cause insulin resistance. So there's a vicious cycle there. Sedentary behavior makes sense. If we're not using our muscles, they're not going to be a very good muscle, glucose sink, and that can lead to insulin resistance in the muscles and can contribute. Stress, poor sleep, both of those can contribute to insulin resistance, predominantly through the release of too much cortisol. And of course, nutrition, because as we've talked about, this is a condition that really is about an overload of energy, and the energy comes from food. So back to that glass of orange juice in this case. So now we have insulin resistance. What happens? We drink the glass of orange juice. It is our 6 teaspoons of sugar, 3 times the amount of glucose circulating in our blood right now. Our beta cells release insulin in response to the glucose levels, and it goes to the muscle. But it's requiring more insulin to store the same amount of glucose. We have to raise more insulin. And then at a certain point, the muscles just aren't taking it up, right? So the muscles are not performing their role as a glucose sink. The liver, of course, can take some glucose as glycogen, but this capacity is limited. So more of that glucose is turned into fat. But with rising insulin levels, when we start to see the insulin levels rise, and especially the basal insulin levels rise, what we see is this pattern of one-way storage. So we can store the energy, the glucose, we can store it as fat, but we can't burn it. And so this is kind of the expression, a moment on the lips, forever on the hips. This is where that comes from. It really is insulin resistance. We eat something, we store it, and then we become hungry again. And so that's what we see with this one-way storage. Over time, fat cells enlarge and lose their ability to store more fat. They get full. And some of that fat spills over and comes back to the muscle, liver, and pancreas. So you get ectopic fat or visceral fat, fat around the organs. Basically, fat starts to go places where it's not meant to be. And this aggravates insulin resistance. In fact, this causes insulin resistance specifically within those tissues. And it's important to kind of think about this for a second. There's 2 ways that we can store fat. So if we're eating too much and we're storing extra energy as fat, we can increase the number of fat cells or we can increase the size of the fat cells. That's it. That's how we're going to store fat. But one thing to keep in mind is that the subcutaneous fat, which is essentially pretty healthy, so subcutaneous, kind of your love handles, what's on your butt or what's on your hips, that subcutaneous number of cells, this number of cells in your subcutaneous fat depots is largely set by the age of 2. So by the age of 2, you have all the cells you're going to get. Now it's the question of how much you can fill them. And this is where this notion of personal fat threshold comes into play. Some people have fewer fat cells than others. Some people's fat cells don't accept as much fat as others. And so these 2 kind of factors will determine the difference really between being overweight and being sick. And this is why sometimes, when we see this personal fat threshold, we see some people that can be quite overweight, um, and their metabolic factors are perfectly fine. And essentially, they're storing their fat in their subcutaneous tissue, and it's not adversely affecting their metabolism. Others have exceeded their fat threshold, and now they're storing that fat in places that's going to affect them. So that's visceral fat or ectopic fat. So that ectopic fat, when you think about it, comes back to the liver. So all the unabsorbed glucose and fat, so the unabsorbed glucose that the muscles no longer take up, and that there isn't room for in terms of creating glycogen in the liver, and the fat that spills over from the fat cells that can no longer accept it, that's going to be dealt with by the liver. And the liver can export that fat, so it can kind of package it up and export it again and ship it out again. And so we start to see, uh, you know, increases in visceral fat, and we start to see triglycerides go up. It can store that fat in the liver, but storing that fat in the liver, as we're going to see, is going to lead to more insulin resistance. Or it can do both, and very often it does both. And let's not forget the other half of the picture with the orange juice. So we talked about glucose, now let's talk about fructose. The fructose is going to go straight to the liver, and it's going to get turned into triglyceride. So when you consume foods high in fructose, when in high in fructose concentration, in a state of insulin resistance, by and large, that fructose will get turned into triglycerides in the liver, just making it worse. Fuel on the fire. Same story with alcohol. The alcohol is going to get converted into fat. Now, go back to our pancreas. We said the pancreas releases insulin in response to glucose levels. But with insulin resistance, that ectopic fat starts to back up into, from the liver, and you start to getting the dysfunctional insulin resistant cells. And these beta cells become dysfunctional and essentially release less insulin. So now we start to see that the pancreas can no longer keep up. And over time, fewer and fewer beta cells have to produce higher and higher levels of insulin to maintain blood sugar control. And when they can't do that, you've got diabetes. So those are kind of the four blows that we see in, happening with the development of type 2 diabetes from insulin resistance. What we see is a breakdown in terms of the muscle's ability to accept glucose. We see that the fat initially is a buffer. The peripheral fat, certainly the subcutaneous fat's a buffer. It breaks down. It can no longer accept the extra energy. The liver now has to take this on, and it starts to back up with fat, and the pancreas eventually is affected. So the four blows that lead to insulin resistance and eventually to type 2 diabetes. Now, all of this, it must be emphasized, comes in a state of energy overload, too many calories over time. So if we step back and look at this from a process perspective and think about our liver and pancreas, too many calories, the muscles being insulin resistant, not taking up enough sugar, the peripheral fat becoming full and starting to spill over its fat, leads to a state where the liver, it gets more and more fat, so this increased liver fat. And from here, that causes directly, when you start getting fat built up in the liver, a decreased response to insulin, and the blood sugars go up. Basically, the balance that we're seeing between the liver's producing 2 teaspoons per hour, the balance with the insulin and glucagon tips, and you start to see that the blood sugars go up because the insulin cannot control the sugars anymore. So in order to accommodate that, the pancreas has to release more basal insulin, and we go around in that circle, and the basal insulin levels start to rise. At the same time, the liver starts to produce triglycerides and produces and exports triglycerides. So the triglycerides, you can see these on your fasting cholesterol or fasting lipid profile, the triglyceride component. For many years, I think doctors would not emphasize this component, and it may actually be the most important component of your lipid profile. That triglyceride gets exported. It's going to be part of a process that leads to increased uptake of fat in the pancreas, and that results in decreased secretion of insulin from the pancreas, and the cycle repeats itself. So this twin cycle or twin trigger theory was developed by Dr. Roy Taylor in Newcastle in the UK, and it explains the process underlying insulin resistance and the development of type 2 diabetes at the liver and pancreas. And so when you look at how to stop this cycle, the work that Taylor has done is very clear. Get rid of the liver fat and you'll decrease the basal insulin requirements and normalize fasting blood sugars. Decreasing basal insulin requirements will also allow you to lose weight. So it allows you to burn fat, which is being suppressed by the high insulin levels. As well, get rid of the pancreas fat and the insulin response to meals will improve. So normalize post-meal blood sugar. So you see these two components, right? If we can get rid of the liver fat and we can get rid of the pancreatic fat, then what we can do is we can normalize the fasting blood sugars and we can normalize the post-meal blood sugars. Now, if we had a magic wand, we'd simply tap the pancreas and we'd tap the liver to see. So how much fat are we talking about? And essentially, it's, in Taylor's work that they did with MRI, it was often around 400 grams. And I must admit, when I first read that, it didn't seem like very much. 400 grams, it's about a pound, right? So if we could tap you and have you lose a pound in the right place, your pancreas would return to normal function and you would be able to control your blood sugars. When you take out a pound of butter and hold it in your hand and think about that being kind of tucked away where your pancreas is, it actually does seem like a little bit more fat. So it's about a pound of fat here, maybe 2 pounds in the liver. So again, three pounds. If we could have a magic wand, we would tap you and lose 3 pounds, and insulin resistance and would disappear at the liver and pancreas, and blood sugars would become under control. Of course, we don't have a magic wand, and so we have to lose weight in another fashion. So let's take a pause here and let's step back and look at this a little bit differently. And let's look at this from the picture of glucose versus insulin over time. So we've talked about this. This is the normal level of glucose, so 5.5 millimoles per liter or less at fasting. And that represents our 1 teaspoon of glucose. And so with insulin resistance, what we see is more and more insulin released over time to maintain the blood sugar. During this time, insulin levels are rising. Weight is probably rising, so you're probably gaining some weight. As it gets higher and higher, you're probably starting to gain some weight in the belly or abdominal or visceral area. But your blood sugars are normal. So many of your checks with your family doctor would be, everything looks okay. We go a little bit further and the insulin plateaus. The pancreas cannot keep up. And so we start to see the deviation of blood sugars. When we see the deviation of blood sugars, we call this prediabetes. And this is what's key. This is 10 to 15 years into this process. We play it out a little bit further, and what we see is at that point, so at this point, at the prediabetes point, what we see is a 50% reduction in pancreatic beta cells, and insulin levels plateau around 2 to 3 times normal. If we play this out a little bit further, what we get is diabetes. We make the diagnosis of diabetes. At this time, probably 80% reduction in pancreatic beta cells. So the fat in the pancreas has affected the beta cells to the point that there's an 80% reduction. The first phase is really all about insulin resistance, and the second phase is really all about decreased insulin secretion. So we come back to that second definition. We've shown how insulin resistance leading to decreased insulin secretion. But the insulin resistance is really all about hyperinsulinemia, too much insulin. And too much insulin in and of itself is a problem. So there's a condition called metabolic syndrome where there are five components to this. You need any 3 out of the 5 to reach a diagnosis of this. And metabolic syndrome is really just too much insulin. Only one of the 5 are abnormal blood sugars. So if we step back and think about it from a mechanism standpoint, if your pancreas can keep up with insulin requirements and continue to produce more and more and more insulin, you may never show an abnormal blood sugar, but you will start to have all the other effects of hyperinsulinemia. And metabolic syndrome and too much insulin is associated with many conditions. So what we see is even though you haven't developed frank diabetes in that case, there are many other abnormalities that you are at risk for, including heart disease. And so we actually will see the increase in heart disease before blood sugars go up because we see it related to too much insulin. So those are the four blows we've talked about, and it's two phases, kind of from insulin resistance to decreased insulin secretion. So let's take a moment to look at this guy. So this is cortisol. It's our stress hormone. And so cortisol directly counteracts insulin. So high levels of cortisol can result in insulin resistance. This makes sense for anybody who's ever taken prednisone and found that the prednisone has knocked them into diabetes or prediabetes. So prednisone is really a synthetic form of cortisol that we take for certain autoimmune conditions as an anti-inflammatory agent. But what happens with cortisol is essentially you mobilize energy because it's a stress hormone. It's all about mobilizing energy. It actually breaks down the healthy peripheral subcutaneous fat and makes some of those fatty acids available. And if they're not taken up and used, because we're not running from something like a saber-toothed tiger in a stressful acute situation, that fat then starts to accumulate in the abdominal or visceral area. Cortisol results in increased glucose production by the liver because it effectively activates more glucagon and inhibits the insulin. And we see more muscle breakdown. And so we see all of these things in people that have too much cortisol. And too much cortisol, when we're looking at it from our perspective here, is really kind of around a couple of different areas. So, but anything that chronically raises cortisol will worsen insulin resistance. So the two areas that we look at this are stress. So increased stress over time will result in higher cortisol levels over time, and that will worsen insulin resistance. Stress also drives appetite, so a double whammy. And guess what? When you're stressed out, you're not craving broccoli, you're craving fat and carbohydrate, and throw a little bit of salt in there just to mix it in. And guess what? That's fast food. That's junk food. That's what you crave, and that's only going to add to the energy overload. And sleep. And so when we look at sleep here, and this is really blow 6, right? Decreased sleep also increases cortisol, also increases appetite. A little bit different mechanisms, same net result. So for our diabetes reversal strategy, we need to look at these 6 components, so 4 plus 2. So there's 4 components directly related, and then the plus 2 relating to cortisol. So the first thing we can do is if we can decrease the amount of carbohydrate, we can decrease the amount of insulin required to be secreted by the pancreas. So there, starting with decreasing sugars and refined carbohydrate, we can decrease our insulin response, decrease the amount of insulin that we need to release in order to control the blood sugars. Of course, number 2, if we can get our glucose sink back in action by increasing exercise and activity, we can restore the muscle's role in acting as this buffer for our health. Third, we've got to be kind to our liver. So definitely want to see less glucose spillover from the muscles. So we've got the muscles back working, less alcohol, less fructose. So we don't want things going to the liver that will get turned into fat. And ultimately, we want to see less fat spillover from the fat cells. And so to do that, we need to start to burn fat. So the first 3 things will help. So if we reduce the insulin levels, increase activity, and less alcohol and fructose, we'll all create conditions that will be able to restore our fat burning. But we need to get the calories underneath. The calories that are coming in need to be less than the calories going out. We've got to stop energy overload, and we've got to create a bit of a deficit. And this is where things like intermittent fasting or time-restricted eating can be very, very useful. We particularly like time-restricted eating in our practice, starting with 12 hours. What's nice with that is essentially it will push or nudge the body towards fat burning. So the body will naturally start to fat burn during the fast. And then what we see is it cuts out nighttime snacking, and overall people that eat in a 12-hour window eat less than people that eat in an 18-hour window. Finally, we can take time-restricted eating and we can extend that out from 12 hours to 14 hours or to 16 hours. So when we look at how to stop the cycle, we want to lose the weight. So we definitely need to lose weight, and we want to get rid of the liver fat, and we want to get rid of the pancreas fat. But we don't have the magic wand, so we have to do this essentially by losing weight in general. So there's laid out kind of the 4 and the 4+2. Whole food, low carbohydrate will help decrease the insulin levels, restore fat burning. Increase activity, we can look at different types of exercise. Really, in the context of insulin resistance, they're all going to help. Being kind to your liver, so decreasing, eliminating alcohol and fructose, we've talked about, stop adding fat, adding to liver fat. Gut health plays a clear role here because of the gut-liver axis, so we have to look at that. All to restore fat burning, and we need to lose weight. The +2 really deals with cortisol. So we want to improve our sleep and learn how to de-stress, learn how to tolerate stress better. And if we can do that, we can decrease the cortisol and decrease the appetite. And there you have it. Went through kind of in detail the process and landed on how to reverse diabetes with a 4+2 strategy. We will, in future presentations, talk more about those individual components, but this will serve kind of as an overview, something that you can come back to look at the whole picture, which I think is really important. Thank you.